我哋會請另一位主禮嘉賓，耳鼻咽喉頭頸外科臨床專業顧問及應用副教授楊駿文醫生。楊醫生會喺臨床同埋實際應用嘅角度同大家講解下吞嚥困難嘅處理。有請楊醫生。
Hi, good afternoon everyone, and thank you for the introduction and also the kind invitation for this talk. So I'm Dr. Levinho from CHP Rhinology, and we're a team of rhinologists and ENT doctors who specialize in surgery in the rhinology, skull-based surgery. And we push frontiers of old-fashioned rhinology and also in the surgery within our teams of doctors. So the talk today is about dysphagia, and it's related to rhinology because around 90% of taste is actually from old-fashioned. So taste you only have like sweetness, saltiness, umami, bitterness, and everything else actually from that, which is you smell it through the oropharynx, go back to the nasopharynx, and then you taste the sensation. You have the sensation from the nose actually. So dysphagia is a symptom and not a diagnosis. And dysphagia matters because we have a couple of problems because of such as aspiration pneumonia, malnutrition, dehydration, and reduced quality of life. So for today's talk, we'll talk about how swallowing works, and then we talk about common causes in the ENT jurisdiction about for dysphagia and also the treatment and also management options. So the physiology of swallowing, you can see here, this is the human face in a sagittal view. There are three primary phases. The first is the oral phase. Go ahead, Mo. Yeah, so for the oral phase, you form a food bolus with the tongue and also with the mouth. You chew, you form a food bolus, and then the tongue propels the food into the oropharynx, which is the pharyngeal phase. From the pharyngeal phase, the bolus is pushed further down into the esophagus, the hypopharynx, and also the esophagus, and becomes the pharyngeal phase. So just roughly, just how the food is processed in the mouth and becomes what is digested and absorbed. So there's some nervous control of the swallowing system, such as the brain cortex, brainstem swallowing, and also the brain cranial nerves, which is affected by stroke, head injury, malignancies, and the sequelae, cranial nerve injury, and also iatrogenic injury from surgery. And also the muscle groups for swallowing is very important. So we went over the few phases of swallowing before. So for the oral phase, we have the tongue muscles, which are the tongue. There's actually a bunch of muscles in here that propels moves the tongue in such a way that it forms the food bolus and swallows into the oropharynx. And then we have the supra-higher muscles, the pharyngeal constrictors, the longitudinal pharyngeal muscles, and also the cricopharyngeus muscles. Everything propels the food bolus down to the esophagus. And altogether, it's around 25 to 30 pairs of muscles that work together to have the swallowing function. So it's around 50 to 60 individual muscles in total. So for the oropharyngeal esophageal dysphagia, so dysphagia can be separated into oropharyngeal and esophageal. For the oropharyngeal dysphagia, it's mainly everything here. Problem in forming a food bolus and propelling it down to the esophagus. And the rest is the esophageal phase. So there are different symptoms. In the oropharyngeal phase, you might have nasal regurgitation, such as when you eat, it goes back into the nose. Yeah. And you have coughing, choking, and aspiration. That's ENT territory. For esophageal phase, it seems that the food you process in the mouth and oropharynx is very hard to propel down into down the esophagus and to be processed. which the patient will have some sticking sensation and some reflux-related sensation. And also, it can be also divided into mechanical and neurogenic. For mechanical, is basically something that obstructs the upper aerodigestive tract and prevents the food bolus from passing down to the esophagus. For neurogenic, it's mostly functional. There's nothing obstructing, but some neurology conditions affect the function of those muscles. So for the common ENT causes, the most types that we've seen is actually the head and neck malignancies. It's actually a very common complaint, like especially for smokers and drinkers. For the oral phase, if the patient has oral cavity cancer, such as soft palate cancer, tongue cancer, it will be very difficult for them to swallow. The food bolus to be swallowed. If you don't have 即係如果你冇咗啲牙或者冇條脷嘅話，你食東其實都危險，你咀嚼唔到咧，每年都有塞腸嘅個案嘅喎，尤其是老人家咁樣樣。喺我哋生口腔癌嘅病人裏邊，其實都有呢個危險咁樣樣。And the second is the pharyngeal phase, which is affecting the oropharyngeal to hypopharyngeal jurisdictions, which is the cancer over here. So you can chew the food, but you can try to swallow it, but it gets blocked in the neck, somewhere in the neck. So that is what actually happens. And also, there's sometimes some external compressions, such as some thyroid cancer or metastatic lymph node externally blocking the inner aerodigestive tract, so that the patient cannot swallow well. And also that for the malignancies, we have the laryngectomy patients. So what are these patients? So normally we breathe through the larynx and breathe through the nose and the mouth. However, they have surgery so that now the trachea, the part that connects to the lungs, it is directly connected to the neck. And then this part here, it is new. It is a surgically constructed pharynx. So commonly we have these patients, it's called a neopharynx, and after the irradiation and also surgical scarring, it becomes very narrow and becomes stenotic. So patients can still chew, they can still form a food bolus, but they cannot pass it down to the esophagus. And this requires surgical dilation or just bypassing everything, having a percutaneous gastrostomy. And the second of all is the post-irradiation skull-base osteoradial necrosis. So this is like the normal nasopharynx. And after irradiation, actually, there's necrosis of the soft tissues and bones, as you can see here. It affects the patient so that it affects the cranial nerves, affects the central nervous system, such that they have pain and they lost coordination of the oropharyngeal muscles and therefore cannot swallow. And third of all, this is very common in our locality and in the ENT area. It's called the post-irradiation soft tissue fibrosis. So just imagine, usually we have soft tissues. When you swallow, the larynx moves up and down. But after radiotherapy, it becomes fibrotic. So it becomes very thick and it becomes very hard. The larynx doesn't move up and down freely anymore. So the swallowing function, although the oropharynx is patent, but since the function of the moving up and down and the contraction of the muscles is affected, the patient also may not be able to swallow well. So for investigations, we have like a number of investigations, such as clinical swallowing evaluation, in which commonly we have a speech therapist testing multiple thickeners for the patient to see if they can be fed orally or they need non-oral feeding. Second is the functional endoscopic evaluation swallowing, using an endoscope and observe how they swallow to see if there's any penetration, aspiration, etc. Fetal fluoroscope swallowing study is also very similar. And sometimes we use some imaging studies such as computer tomography, magnetic resonance imaging such as CT MRI, and also some barium swallowing, which is also an imaging modality. And sometimes, I think less frequently we use high-resolution manometry, which is very hard to do, and also sometimes ultrasound. So just as, I think the most frequent thing is actually the first two, clinical swallowing evaluation and endoscopic evaluation of the swallowing. So for management, if it's cancer, then likely it needs either surgery or chemotherapy or radiotherapy. So all these patients with the head and neck cancers, their swallowing will be affected in one way or another. Either pain or loss of function of some of the muscles, or stenosis or strictures of some of the lumens that passes the food. Sometimes patients have some functional surgery, such as diverticulum, which is an outpouching, soft tissue outpouching in the neck that you need to close it, or else it will collect some food and have many problems such as abscess formation. And also, sometimes when the patient has strictures in the neopharynx, such as the laryngectomy patients, they need an endoscopic procedure such as serial dilation. So if the neopharynx is very strict, it's very narrow, then we serially dilate it, made it wider, so that when you chew the food, it can pass down to the esophagus. And also some diversion procedures such as the percutaneous gastrostomy, which is the having a hole put in the stomach, you bypass everything up there and just putting the food to the stomach. So for non-surgical and non-medical management, we have the diet modification, which is why we're here today. You have thickened foods in gradation of thickness, and also there's soft diet and also non-oral feeding. So non-oral feeding is something that we try to avoid if possible, because non-oral feeding means you have a plastic tube going into the nose to the stomach, and first of all, it's very hard to maintain. Sometimes it gets blocked, and then patients need to go to the emergency department to be exchanged. It's very uncomfortable, and it's not without risks, because sometimes we have some cases of lumen perforation with the plastic tube itself. Yeah. And also that patients feel that they cannot enjoy the food. They cannot enjoy the food. It's a very big impact on the quality of life. And also some rehab treatments such as oral motor exercises, training the mouth and oropharyngeal muscles to swallow again. There's some evidence that it works, and it is routinely given in our department. And also some compensatory strategies and patient and family education. And also this is something that we're all very familiar, the International Dysphagia Diet Standardization Initiative Framework. It just basically standardized all the puree, the liquid, the thickness of the food into standardized coloring and categorizations, which is what the machine out there do. And also, at last, I want to talk about aspiration, which is something that we really don't want to see. We have thickeners because we want to prevent aspiration. If the elderly patient or an ENT patient who is doesn't have a good swallowing function, if they drink fluids without good thickeners, it goes into their airway, and it goes into their lungs. And it's very dangerous for especially elderly patients. If they get pneumonia, if they can, before pneumonia or aspiration, maybe they can take care of themselves. Once they get pneumonia and they get bed rested for maybe a few days, after that they may be very deconditioned starting then. They'll not be able to walk, they'll not be able to take care of themselves, and yeah. And especially the patients who have ICU care because of pneumonia, it's very poor prognosis usually. So yes, for the high-risk populations is the 75 years or older, and account for 76% of aspiration-related deaths. So this is my presentation, and thank you very much for your time. Thank you.
各位有冇問題想請教楊醫生㗎？中文都可以。 好，相信楊醫生嘅分享都好詳盡，所以大家都冇乜其他嘅問題啦。咁經過兩位醫生嘅專業講解啦，大家對於軟餐同埋吞嚥安全咧都有更全面嘅認識喎。咁我哋請大家再次熱烈嘅掌聲，多謝方博士啦。嚟緊落嚟咧，我哋有今日其中一個重要嘅環節啦。咁大家有冇少少肚餓啦？而家都係 Happy Friday 嘅 tea time。咁我哋喺對面嘅活動室咧，就準備好一系列咧ProTHIX製作嘅軟餐啦，同埋佢哋相關嘅產品咧，可以俾大家試食同埋睇下佢哋個質感啊、造型咁樣嘅，亦都可以同我哋唔同嘅團隊交流下啦，了解下產品嘅應用嘅。咁稍後咧，工作人員會指示大家移步去對面嘅活動室嘅。咁另外想大家即係輕輕提一提，我哋活動室嘅門口咧會準備咗少量嘅現貨啦，可以俾大家業界嘅朋友可以選購買翻去，可以試下嗰個軟餐啦。咁我哋其實咧都積極咁開拓緊唔同嘅市場啦，包括醫護市場等等嘅相關服務嘅市場嘅。咁希望可以同在場嘅每一位合作，咁啊推動軟餐嘅發展。咁另外我哋如果譬如對產品日後有一啲即係更有興趣嘅話啦，我哋都有啲預購單嘅，咁我哋可以填寫咗留翻個資料，我哋到貨嘅時候會通知大家。咁預購係唔收任何費用嘅。咁再次大家多謝大家嘅嚟臨同埋支持啦，亦多謝各位嘉賓啦，同埋我哋團隊嘅努力同埋分享嘅。希望今日嘅活動可以為大家帶嚟新嘅啟發啦，一齊推動呢個軟餐文化向更高質素嘅發展。多謝大家。
好，咁再一次多謝楊醫生啦，咁啊第一次都啱翻咗診所啦，咁亦都再一次多謝咧咁多位業界嘅好嘅朋友，好嘛？咁遠道而嚟我哋科學園裏面咧參加呢個咁嘅盛會，嗱咁我諗現階段裏面咧，我哋嘅分享就喺呢度裏面咧就完，不過最精彩仲有一部分係點啊？請移玉步過隔離咧，就去試味啦。我哋嗰度咧有一啲嘅鮑魚，當中裏面咧大家知鮑魚好韌啊嘛，係咪？嗰啲老友記咧，通常咧就冇牙冇齒嗰啲咧，即係楊醫生話齋，佢吞嚥嗰啲肌肉啊都搞唔掂咯，點吞咧？係咪咁吞啊食糊仔？而家唔使啦，可以食鮑魚。咁你哋咧全部都係有牙有齒，咁但係唔緊要，因為我做到咧嗰個軟餐裏面一齊俾翻老友記咧，你唔好用牙咬喎，用個口同埋嗰條脷咧去揹佢得㗎啦，好唔好啊？嗱有鮑魚啦，有龍蝦啦，有西蘭花啦，有冬菇啦，咩都有㗎啦。咁你去到嗰邊咧就問我哋嘅同事啲大廚嚟㗎，亦都有咧。好快要過年咯喎，係咪啊？咁即係出年單即係，咁但係點知咧？我哋食品業界嘅咧，即使我哋嘅過年嘅年糕或者過年嘅蘿蔔糕，就唔會出年頭先做㗎嘛，係點啊？半年前已經做定㗎啦嘛，要出口啲人甚至再早年已經聽幾個數量啊，聽到啦嘛。有一樣嘢，大家陣去到蘿蔔糕嗰邊咧，你就睇到啦，軟餐咧試下食先，食完之後咧，原來個ProTHIX裏面咧做正常餐都得㗎喎。原來咧係可以將我哋蘿蔔糕點啊封神之後，即係當然啦。你去到一陣間咧，就見到一位好大隻着住制服嘅 Raymond 廚師 Raymond 啊，阿 Chef Raymond。咁你問佢喂點樣做你嗰個咁嘅正常餐嘅蘿蔔糕係用ProTHIX去做咧？可以封神解凍之後咧，整翻出嚟咧，同真嘅正常嘅係完全一模一樣嘅。好嘛？咁日後裏面你哋嘅蘿蔔糕咧，可以點樣啊？飛出去外邊嗰個試試翻嘅。好嘛？咁嗱呢啲咧就你哋做啦。咁我哋咧業界裏面嘅痛點交行去到我哋呢邊，好嘛？嚟到我呢邊我盡量諗辦法點啊，幫你解決你個痛點。點樣做生意？你哋自己辦法成個你哋嘅成方文之成，得唔得？我哋淨係做咩啊 R&D。咁好嘛？咁我喺一度裏面咧，再一次好誠懇、好坦誠咁咧，多謝各位好朋友人。當中裏面咧，我有來自日本嘅朋友仔啦，有來自馬來西亞嘅朋友仔啦，有來自我哋灣區嘅朋友仔啦，好多，我哋5回4我都睇晒住。咁大家唔好係啦，我話你英文又得，國語又得，咩話咧？你溝通到你都可以 feel free 啦，一陣間好唔好啊？好啊，嗱咁而家咧就請移動過我哋嘅同事咧就帶你過去隔離嗰邊咧去品嚐你嘅軟餐，同埋仲有好多嘅飲品嘅，咁你。